today's seminar in the C6 seminar series. My name is Eyal Cohen. I'm a pediatrician at the Hospital for Sick Children in Toronto. Today's seminar is one of a series that has been focused on the clinical care of children with neurodisability and medical complexity. The C6 seminar stands for Collaborative Conversations with Families to Advance the Clinical Care of Children with Medical Complexities and Disabilities. It is a 10-part seminar series that is generously supported by the Lucille Packard Foundation for Children's Health in partnership with Family Voices. We're really excited to have you all join us today and look forward to your participation, discussion, and engagement throughout the seminar. Today's seminar is a bit different than other ones that we've had in the past, which have been very content focused, but a universal thread throughout the C6 seminar series has been around partnership with families, co-leadership and decision-making, and really the topic that we're going to focus on today, which is around shared decision-making. How do we make decisions together as healthcare providers with families and patients that's in the best interest of those that we serve in healthcare? We want to acknowledge, as we do in all of our sessions, that each healthcare encounter is unique, be it brief or lengthy, and that many of the topics that we're discussing in this series and some of the discussions that we're having are difficult to address by virtue of the fact that a lot of the series really focuses on big gaps in research. And while we can't overcome this issue and cover the breadth of every topic, we aim at least to highlight the cooperative need and value of partnerships. So just a few housekeeping reminders. Please remember to submit any questions or comments you have in the webinar in the Q&A. Once we've concluded the presentations, we will move on to a panel discussion. We will try to get to as many questions as possible. And then following the webinar, you will also be asked to complete an evaluation survey. This is really important to us. We review these after each session and give us an opportunity to improve the seminars that we've been delivering. You'll need to complete the evaluation by Monday, January 24th, in order to claim any CME credits for today's seminar. And those of you who are enrolled in that will receive details on how to claim your credits by email. Based on the rich discussions that we've had and the high volumes of questions and feedback, we add 30 minutes to the end of every conversation, and anyone who wants to stay for a virtual coffee chat from 2 to 2:30 p.m. Eastern Standard Time is welcome to stay. If you can't stay, we record all our sessions and post them on the Packard website, and the Cafe Q&A portion will be included in this recording. Our aim for this seminar series is to create a seminar series that is supportive and a safe space where we have important discussions that ultimately help to improve clinical care. We partner with families for this series because their participation is essential for our goal of improving clinical care. Families are our clinical partners in care by virtue of the fact that they're involved in care delivery and care decision-making 24 hours a day, 7 days a week, and their experiences and perspectives matter. They matter a lot. However, by virtue of the way we're delivering this form, which is large and virtual, and by nature of some of the discussions, which are sometimes difficult and involve lived experiences and lived examples that may resurface a variety of reactions from participants, we understand that these conversations may be difficult. If anyone needs any support after attending the sessions, we invite you to reach out, and the links will be shared with you in the chat box for clinicians, for people experiencing medical complexity, and for their family caregivers. We're delighted and honored today to welcome our two family leaders. It's Jill and Brennan McCormick, who have joined us today. I'm going to introduce Jill first. Jill McCormick has been the program director for the Washington State Family to Family Health Information Center at PAVE for the last 9 years, and has worked for 25 years, over 25 years, in the disability and special healthcare needs community in different capacities with individuals and families across the lifespan. She's a parent of 3 young adults impacted by special healthcare needs, a 27-year-old son with autism spectrum, a 24-year-old daughter on the autism spectrum, impacted also by behavioral challenges and moderate asthma, and a 20-year-old son, Brennan, who you will meet today as well, who lives with a complex heart condition. Jill, I'd like to invite you to share some experiences you've had in raising children with medical complexity and shared decision-making. Can you please share what you see as the important implications for change?
Good day, everyone. And I need to correct one thing. Brennan is 21 and he's soon to be 22. So sorry about that, Brennan. I think when I thought about this, all three of my kids have been a part of shared decision making. Two of them fit in that neurodiverse kind of space, but Brennan has been the highest impact as far as medical complexity. And Brennan has been our highest impact journey as far as having to spend time with physicians, trying to navigate new spaces, trying to understand new avenues, because things happened so quickly with him, because things were life-threatening with him. He was diagnosed at 7, and he had a high cardiac event at 8, 6 months after diagnosis. He had he went into cardiac arrest. He aspirated during CPR, his dad and his uncle. He was medevac to Seattle Children's. We got there and they told us when we got there that his lungs weren't working. I didn't know what that meant. I went there expecting to bring my child home. And they were like, okay, well, we're going to ECMO him. I didn't know what ECMO meant. And I didn't know what that, so they, it was like, so what's happening, you know? And it took a while to kind of get a rhythm going in getting information going and having the people understand that if they told us what was happening and explained to us what was going on, it was easier for us to give them information as well and spend time. We were there for 8 weeks. He was ventilated for 6 weeks. And during that time, it took time to develop those conversations with the physicians, to develop those conversations with the teams, because it was easier with the ECMO teams because they were in the room 24/7. So I was there, the nurses were there, the doctors would come through 24/7. So, but once ECMO teams went out and he was in ICU, then the teams rotated and I'd have to start the conversations over and over again. And when he crashed 3 times during that, and having to have those conversations with the team and going, wait a minute, I'm seeing this happen, and having them understand that I kind of actually knew what I was talking about. And I knew because I'd been there and I'd been listening to what was happening, and that I was a part of rounds every morning. And because I understood that things were happening with his temperature and with the medications that were happening, it took a while for the trust factor to happen for the teams as they rotated through. That was a long time to be in the hospital. It is a trust factor for physicians. It is a trust factor. And you, in a teaching hospital, you have fellows, and fellows don't always have the same history with families that physicians do. They don't always have the same, it isn't always taught in when you're learning that dynamic of listening to parents, the parents have that expertise with their children. So the fellows were those people that I had to build that relationship. Those were the individuals that I had to, that often caused the stress and the trauma in the way that they presented information for me, that we had to backtrack and go, okay, now what does that mean? And wait, where are we talking about? And so we got there. And as you can see, we got there. The next step was then, as we got home, building those relationships with his team over the years, and making decisions on next steps and the long term. What's the long haul look like? And what are the decisions on the devices that kept him going? What do we look at with his heart, and the physical expectations of his heart said his body should react one way, but the electrical aspects of his heart didn't follow that norm. So it was like reminding them, yeah, you say he should react this way, but in all actuality, if you remember last time, it was this way, and his recovery is much longer. So I need you to remember and follow those things, and then pulling him in and saying and helping him start to be the driver of his self-care as he got older, and having him ask the questions, so that when it got to the place where he couldn't go to school was from home, starting in 9th grade, and he got to the place where he was home. That's where he lived, was in our house, that he could ask the right questions, that he could follow that rabbit hole and decide and make the decisions for a transplant. And he knew what to ask. He knew how to talk to his team, and he could make those decisions with an informed insight. And we could trust that he knew what he was asking, and we could trust that he made those decisions. And so it was important to us that he made informed decisions, and that we had a long relationship with his physicians, and that we were a team. And so I kind of push it over to you, son.
Oh, if you're ready for me, yeah. To add on to what she was saying, my long haul, my transitional piece was eventually in 2019, I had my heart transplant, which was very fast. I didn't expect it to come at me so quick. It was, I think, 4 months after I finished all my evaluations, which led to a lot of, stress in that regard. And I had some atypical solutions that I had to address with my teams past, I did all the typical stuff of the waivers and all that, and talked with my doctors about those, sure, but my real challenges came after the surgery, such with pain management. The golden standard is you're on narcotics for a while. They treat your pain really well, and they're great at what they do, except I have never had a great history after surgeries with being able to keep food down, and my gut health just was never great. So for me, it was atypical, where I felt every time I took narcotics, I just vomited all the food that I had the same day, which caused a whole lot of weight loss for me that my nutritionists were starting to get concerned while I was inpatient. So I started suggesting, maybe I back off the narcotics and I try a different type of pain management. I'll take Tylenol, I'll take this. And ICU nurses and my doctors were a little bit hesitant at that first, because pretty big surgery. I don't know if Tylenol or something like that can treat it. So they bargained with me for a little bit. Maybe I take half of what my dose was, or I take a different type of liquid instead of oral pill. which, it kind of helped, but I was still losing weight. So my doctors were rotating out in and out until I finally had a doctor that said, okay, well, we'll try Tylenol for a few days, see if that helps. And eventually, for the most part, that's what I stuck with. Another example would be about two weeks, maybe a week and a half after. I moved rooms, but they were talking that I had these little air pockets in my lungs. Nothing, immediate danger, nothing. Just use your little breathing exercises that we gave you, all that, and they should clear out. And when they weren't quite clearing out at the rate they expected, they, had immediate, like, we can do a surgery, 30 minutes to an hour, really simple surgery, would get rid of it 100%. But I don't think they quite considered, I wasn't quite comfortable with another surgery yet. It kind of hurt just to sit up or move a little bit, and that would mean I'd have to go lie down on another table, which was kind of painful for me at the time. And I'd have to go under anesthesia again, which made me, very nauseous, which was one of the reasons why I couldn't hold down food. So I kind of pushed back on that. I said, well, is there any other thing I could do? Maybe wait another half a week, see if anything gets a little better, until I had another, doctor shift where they said, okay, well, it's not 100%, but we can try a oxygen therapy treatment. You'll basically be on oxygen 24/7 for, a week and a half. And if that doesn't show results, then, we'll do the quick surgery and fix it out. And turns out the oxygen therapy cleared out any of their concerns. So I'm glad I kind of pushed back on that to something I was more comfortable with, and it ended up working out for me. And my last, I guess, the main example that I have of conversing and working out is I had a lot of atypical heartbeats and rhythms right after transplant. I was on a external pacemaker for the first week and a half. They ended up taking me off it, of course, but I was still having a lot of what they call PVCs, which are premature ventricular contractions, which for the most part, that was true, but mainly during night, I would feel certain runs of it, which I thought, was tachycardia. I've experienced that before with my heart disease, and that's what it felt like to me. But whenever I would bring it up, they, check their machines that I was hooked up to, and they say, well, no, your runs weren't quite long enough. Those were PVCs still. They didn't quite go into the realm of tachycardia. And I said, okay, well, I'm sure you're right, but if you could, I wrote down times here. If you could just go check, and it would give me some peace of mind, maybe. And it turns out, a few of those runs were the tachycardia that I was kind of concerned about. Why am I having that? And it ended up putting me on my same beta blocker that I was on beforehand. For, I don't know, I just came off it 6 months ago or so. So it was a good conversational piece that I had with all my doctors that were in and out rounds, because I'd probably transitioned between maybe 6 different, cardiologists, because they'd all swap out in rounds and throughout the weeks. So it was interesting for how some doctors, were a little bit more lenient with my suggestions, and some were a bit more stern to their golden standard. So my main takeaway, and what I've all learned from it, is, while I understand, golden standard treatment is there for a reason, it works for most folks. It's important to listen to the people that know their bodies really well, and who are, in tune with it, because they've lived with it their whole life. And it's always good to be a little bit lenient where you can in treatment or just your ways of thinking. That's what I have for now.
Thanks, Jill and Brennan, and I'm looking forward to hearing more of your thoughts in our panel discussion. I just want to highlight a couple of comments in the box. Jill, you spoke really nicely about the importance of transitions for youth, and I just want to highlight Lauren put in the box that there is an upcoming webinar on the 19th of January on healthcare transitions from GOT Transitions, and there's a link to that in the box. And other great comments about the story you told us about your own journey, Brennan and Jill as well. So thank you very much for sharing that. I'd like to now turn to David Fox, who will be speaking next. Dr. Fox is an assistant professor of general pediatrics at the University of Colorado School of Medicine, a pediatrician at Children's Hospital Colorado. He has clinical interests that focus on primary care for children with medical complexity and research interests in shared decision-making and how it can promote better care for children with medical complexity, specifically looking at decisions around elective surgeries like feeding tube insertion, surgery for gastroesophageal reflux. He tries to understand the hopes that each patient has and each parent has for their child and family to make sure that all treatments align with those goals. So I'll turn over to you, Dr. Fox. Remember, everybody, please feel free to submit your questions in the chat for discussion.
Eyal, thanks for that nice introduction. And I just want to say before we begin to Jill and to Brennan, thank you for sharing your experiences. I'm sure that that was not easy to go through at the time, and really does help people learn about how we can better care for young people with complex medical problems. I'm going to go ahead and share my screen with some slides, and bear with me for a moment. Okay. Someone feel free to let me know if things aren't going well with the slides, but the main focus of what I wanted to talk about today is about listening. And I think you heard it with both what Brennan and Jill talked about. Is to me, I think listening is the key to shared decision making. And that's why I tried to keep it so simple as far as the title of what I wanted to talk about. And along the way, my colleague Jody was going to talk a little bit about some of the definitions and more of the research uncertainty surrounding shared decision making. I'll highlight some of those since she was not able to be with us today. No financial disclosures that I need to discuss today. I tried to keep it simple because I'm a sort of a big picture person, and I need to. This is the way I communicate it. And I think these are the four things I want to highlight today. Listening, for goodness sakes, I can't believe we even have to say it. That's the most important thing. But to me, it is for an encounter between a patient, the family, and providers. Connection. I think making a connection with your patients, making a connection with your providers, I think it's essential. Trust is the key, and I just want you to reflect about important decisions you make in your life outside of the context of medical decisions. Whether it's a financial decision, whether you're going to buy a car, whether you're whatever it is that you may be doing. If there's no trust between you and the person you're working with, well, I would get out and try something else, try another strategy, because that's bad. And deciding together, I think, is what we're after. I put this slide up because just to sort of reflect on the context in which I work. And I work over on the left there in a complex care clinic where I'm a general pediatrician, and I mainly see children and adults with complex medical conditions. The family's the center, the family's the key to me, and subspecialists are obviously we can't do anything without subspecialty expertise, whether it's procedures, whether it's medications, whatever it is, diagnosis, we need them. And communicating amongst those three groups is challenging. challenging. And I think it's really an important part of what we do. When we talk about shared decision-making on a global level or a national level within healthcare, we talk about exchanging knowledge, exchanging preferences, and exchanging values, and then making a decision going forward. That's sort of the standard is for medical decisions. There's a lot of shared decision-making literature and research. A lot of it is in the adult world around cancer and cancer diagnosis and testing and cardiac procedures. There's a lot of great work being done around shared decision making. In other words, how can we as a group, patients and families and providers, promote shared decision making? And a lot of what folks do is create tools for specific decisions. Perhaps that's a tool that would be related to choosing to start treatment for attention deficit disorder. That's an area where there's been some research. Or it might be choosing to consider whether or not you're going to have a certain cardiac procedure. Again, a specific tool to help with that decision. That's where a lot of the research lands in this area. But I want to take a little bit more of a global view, and I do this with this metaphor on the screen here that I hope you'll just sort of engage with for a moment. To give you an idea, I think what doctors and other providers are trained to do and what we need to be trained to do. On the left, you see a maze. Maybe I remember doing this on the cereal box as a young kid with a pen or a pencil, getting through it. And for many things in medicine and many things in medical training, this is the model. We have a problem. We got to get through this maze and we got to get out. There's a diagnosis. We're going to get a diagnosis. We're going to do a treatment, and then we're going to move on. Now, admittedly, sometimes that's the case. You know, if a young person comes in with the concerns for maybe there's an ear infection, finding that ear infection, treating that ear infection, done. But I think my experience is that for children with medical complexity and for families, that the model on the right is perhaps a better way to conceptualize things. It's a labyrinth. Perhaps you've seen them before. We know it, whether we like to admit it or not. We're all headed toward an ultimate goal, an ultimate place that we're going to be, and it's a journey. And I think as providers, as nurses, as nurse practitioners, as physician assistants and physicians, we need to think about being with families as they move along this journey. So how do we make this connection? This is a terrific part of the literature that was done by Dr. Zollman just now it's 2 years ago. That some of the practices, and these are the things I try to promote with young providers and my colleagues, that these are 5 ways we can connect with families and patients: preparing, listening, agreeing on an agenda, trying to make that connection with the patient's story, and also exploring emotional cues. I'll just show you that where the study comes from. It's a mixed method study that talked about how to foster connection with families, and really a well done study. Literature review. There was combined with observation of primary care encounters. There were physician interviews. There were also interviews with other people who have expertise in managing with families. Boy, I can't say enough about how great social workers are in talking with families. Goodness, they have so many skills. So I'm glad that it was incorporated into this. And what they came up with were these 5 practices that were most feasible to implement and would have the highest impact. And the one, as you could guess from my first slide, that I'm going to focus on the most is listening. And again, I don't want to say it's a little sad, but maybe it's a commentary on where we are as a society, that I have to highlight that listening is the most important part. It's an essential part of the physician, of the provider and family encounter. There are skills you can develop as to how to listen and to do reflective listening, taking your time, making sure that all of the concerns are put out there. I had an experience just a couple months ago where I went to a physician for a medical concern, and I counted. I got through about 6 seconds before I got interrupted by the provider. Now, the provider's a very nice person. It's not that they're a bad person or they're rude, but you know, it is a habit that we have, and it's a bad habit of interrupting folks. Pardon me. So again, here are the 4 things we're trying to do: listen and make that connection. And so here's a little vignette that I want to talk to you about the power of listening. The power of listening. It's one of my favorite patients. Whenever I see him on the schedule, I think to myself, this is going to be a good day. Because I'll be honest, I always get a good hug from him. Really, he's always really glad to see me. He's got very severe medical problems: asthma, severe scoliosis. He had spinal fusion surgery. He's got very bad obstructive sleep apnea and now has heart disease related to that. Now, the concerns that are initially in our notes and there's very minor: a rash behind both ears, some flaking in the scalp. To be honest with you, as a provider with some experience under my belt, I could diagnose that without going in the room as to what that's going to be. And needing refills, I could have done that by phone. That's not why I'm there. That's not the key piece. The what else? After I got those concerns from mom, we didn't address those. I said, what else? Is there anything else going on that you wanted to talk about? Because I wanted to give the family and mom space to talk. She's a wonderful person, school teacher, and she is just on the edge, at this time was on the edge of about to retire. And she has no idea how she's going to manage who's still, you know, a young man. And she's really confused and starts crying. The point I want to bring up here is that the connection that we made that day, in that encounter, in that sharing, has been the key to our relationship going forward. I've known her now. This encounter happened probably about 2-3 years ago. It's the key. It was the turning point. It was the most important point. Clearly, I've got to take care of the flaking behind the scalp. I'm not saying I'm not going to ignore it. I'm going to ignore that. But that emotional connection that I have with and his mother is key. And I think the reason it came is because I listened and I gave them the chance, mom, the chance to say what she wanted to say. This is a model for shared decision-making by a fantastically talented researcher, Glenn Elwin. And it's pretty complicated. Team talk, option talk, decision talk. You know, there's a lot of, I get a little confused when I look at a model like this, because I think to myself, well, how do I enter this? How do we begin to talk, to do shared decision-making? Things happen so fast. But as a brilliant guy, he put it right in the middle there. You see it: active listening, paying close attention and responding accurately. You know, I came back to this model after having looked at it, you know, many years ago when it was first put out in other versions. And I'll be honest with you, the listening piece was not the piece I was focused on at the first time I looked at this, but it is now, because I've come to realize with time and experience is that's the key to beginning, is listening. Because we have a lot of decisions to make, as I already have reflected on, that I don't do the surgery to put the G tube in. I don't do the surgery to put the tracheostomy in, but I am there helping families through that decision, decisions about referrals for particular problems that are coming up. The next piece, the next part of this vignette I want to talk about are 2 patients, and doctors love to do this. They love to show X-rays and talk about patients. in this way. But the reason I put their x-rays up is that these two young men, well, they both had the same diagnosis. I know them both and I've had the privilege of caring for them over the past several years. We'll call the young man on the left Jose, and the man on the right, young man on the right, Nate. And this is an x-ray from back when they were under 10 years of age. And you can see that they're, well, an astute observer will note for the patient on the left has a little bit of mild scoliosis there on the bottom. The spine is curving just a little bit, but the other x-ray is relatively normal. And the reason I bring the x-ray up is because I want you to focus on the spine. And this is an x-ray more recently that I'm going to show next. And you can see the changes that have happened. Goodness. On the left, Jose and his family decided to go ahead with spinal fusion surgery to stabilize that spine, put those rods in. You can see those metal rods there. And then on the right, Nate and his family decided not to do that. And you can see it's a little bit harder to see perhaps for the untrained eye, but that there is pretty significant scoliosis. Again, both these young men have Duchenne's muscular dystrophy, and just by chance, perhaps not by chance, but I've seen both of them in the past week. And I continue to remind myself that the most important piece of what has gone on in their care is the fact that I began with listening and I tried to understand what they wanted. They have made very different decisions, as you can see. In the past, I may have thought, boy, the right medical decision is the left. I've changed my mind about how to approach this. The right medical decision for Jose was what happened on the left, and the right medical decision for Nate is what happened on the right. And I think coming to realize that it's not my decision, it's our decision. That's why they call it shared decision making. And it's remarkable to me that and notable to say that the relationship is the key piece. I've had the privilege, I've known them for more than 10 years, and it's been extraordinary. I've just put the list here of surgical and medical decisions. So many decisions, they happen all the time. And sometimes they happen in a complex care setting. Sometimes they happen on the inpatient setting. Sometimes they happen in a specialist office. But there are a lot of singular decisions that we can think of and that we can talk through. And again, some people on the research end of things may try to develop and are developing decision-making tools, pieces of paper or videos that will help people make these specific decisions. But again, I think the key message I want to give to you today is that all of these decisions are dependent upon trust. And to get to trust, you got to listen. To say it again, listen, connect, trust, and then we can decide. And all of these other pieces are important. I think I did hear Jill talk about the team many times during, and Brennan mentioned that as well. We are a team and we are working together. I think the options, number 2 on this model, having those options and having those alternatives, believe me, for Nate, who decided not to do spinal fusion, we talked about it. We talked about what it's going to be like to do spinal fusion and what it would be like not to do it. And those were the hard conversations, but they were important conversations. And then, to making that decision is the key, is the last piece of this model. And again, to highlight what's the starting point? Active listening. I like to keep it simple, as I said. Listen, connect, trust, and then we can decide together.
Thank you, David. There's been some excellent questions that have come through the Q&A, and I'm going to get to them in a minute. I just want to remind people, if you have questions for the panel, please feel free to ask them in the Q&A box. I'd like to now turn to Jill and Brennan to reflect on what Dr. Fox presented today. Wondering if you had any thoughts after listening to his presentation.
You want to go first, Mom, or should I? Ooh, you muted. I maybe that's me. I think one of the things that resonated with me the most was how he said that, well, they were tough discussions, they were important ones. And that was really important for me since I was, 19, going through a heart transplant that all happened very, very quickly to me. I thought I'd have more time to process. I thought I'd have, more time to just get ready for it mentally. And all my, I kind of talked about it pretty calmly here, at least I think, but all those examples that I brought up weren't the easiest thing for me to bring up at the time because I had a lot of discomfort. I just went through, this really big life-changing surgery. So even kind of discussing my care and all that, well, was pretty difficult for me. I did trust all my doctors. I was lucky to have a really, really great team. But it was, it was hard to talk about all these things with composure, which made getting my point out kind of harder because maybe I didn't say things so clearly. I could think it in my head, but it was kind of this emotional talk trying to get it out. So that's where the listening factor was really important so that they could get what I was conveying accurately. Even if I had to, state it, more than once sometimes because it was hard to get out.
I think for me, there's kind of like two things. I think the listening part for families, that isn't always what we experience. There are systems that do that well, but there are systems that don't. There are systems that we are the experts. We're going to tell you, and we want you to follow what we tell you to do. And so I that's good to hear, and hopefully that will follow through, that people will understand and start to, that there's some change will start to happen. I think that your example is incredibly powerful. I think that that showing that colleagues are going to twinge because the fix is going to be what's going to want to happen, and that it's going to be hard to see the not fix as the right choice. And I think, and I know that as in that transition period, also, there is also, as a parent, there is some challenge transitioning to young adult decisions. There is challenges in conversations between physicians and parents and young adults, and that decision dynamic that happens, that can be a challenge, and finding that balance for the care of a young adult who might have developmental challenges, or who might have a behavioral health challenge where not everybody's on the same page. So I think that there are instances where we haven't gotten there yet. That there's still work to be done, that that all of us have places where I don't know. I still, you know, there were times when especially with the pain place, to me, it was like, why do you not want to take stuff that will make you not hurt? And I didn't hear that I'm throwing up and I can't eat when I take this medication. And I knew he wasn't gaining weight. I knew that he was like at 5 percentile. They were really concerned about his weight loss, but I didn't connect that the narcotics were linking to that. And so sometimes we don't connect also with what our kids are saying. So I think it's important for all of us to listen, is where I'm trying to get to, is we all need to listen to the patient. We need to listen to our kids as well as the physicians. Sorry, I kind of went down a rabbit hole there.
Thanks, guys. This is an excellent segue to a group discussion. And I've already received a whole bunch of outstanding questions, which we'll continue to discuss even after the formal part of today's session ends in 10 minutes or so. So if anyone wants to stay on for the virtual cafe, we'll continue to go through these questions and push this discussion forward. So I'd like to start by asking the panel some questions that have come in the Q&A. The first question, it's actually addressed to Jill and Brennan, but I'd like David to also reflect on this as well. If you had a magic wand and could fund any type of research or develop any kind of product to promote shared decisions, what kind of work would you like to see being done?
Do you have any ideas on that, Mom? I need to think for just a second.
Wand and product. I don't know. I think that there's lots of things that have started on shared decision making. I think that one thing that I think there are two places that I think the beginning of it needs to happen, that it doesn't happen. I think it happens kind of in the middle and at the end, but it doesn't happen at the beginning. So I don't think it happens in the beginning of teaching for physicians and nurses, and that process, that understanding that it isn't a part of curriculum. What that is, what that means, what that is. And I don't think that it's a part of education for school, because I think special education, I don't think it's a part of that whole process around these kids, for these families, for the support of the families, for the support of these children, in the totality of their lives. I think that that when a family is handed a diagnosis, a condition, that they are not handed, and here's how we're going to talk about this. Here is how we're going to make choices together around your child. Here is how we're going to move forward as a team in your journey with your child. That doesn't happen. It's usually, well, here you go. And out the door you go, and you have to figure it out on your own. You have to go down the Google rabbit hole, and maybe you might have a physician that knows there might be an F2F out there, or a parent-to-parent out there, or a condition-specific family support organization, or maybe not. And you may have a physician who might think that that's okay, and you may have a physician who doesn't, who may or may not trust family support organizations. So I think for there to be a more cohesive understanding that wraparound is important, that wraparound is how families are resilient, is how you get better outcomes, is how you have long-term health care outcomes. That would be my magic one.
I read something in chat that I agreed with as well while my mom was talking. Sandra said training with med students would be a great start. Not to bash any of my nurses, they all did a great job, but that's where some of my problems and my inpatient stemmed from. I'd communicate something with the nurse and it wouldn't always come out the same way to the doctor. I'd meet with my cardiologist, physicians, etc., maybe once, sometimes twice a day, and then with rounds. And in the in-between, I would talk to my nurses about everything. They'd either manage just me or me in another room typically. And I think, to link back to some of my, tachycardia problems, I think that's where some of it stemmed. Was I'd have, nurses go check the alerts that my things are giving me or things like that. And, they could convey it to the doctor, of course. But maybe they didn't have, enough training to go look and see what that actually says or whatever, because, they're not cardiologists exactly, or other things like that. So yeah, some of my issues just stemmed from maybe the nurses, were doing their best to, listen and convey, but it didn't always come out the exact way I needed to or specified.
David?
For me, I had a recent, the past couple of years, I've been involved with a communication workshop, and that's been transformative for my career to help me become a better communicator and to help me become a better listener. I give the analogy of driving. I drive every day of my life, just about. That doesn't make me a good driver. If I wanted to be a great driver, I could use somebody who watches me and who gives me some tips, and or do a little workshop on how to be be a better defensive driver, or whatever the case may be. Same thing with medical practices. I could use some work on that. Most of CME, continuing medical education, is focused around knowledge. And that's good, that's important. Knowledge saves lives. But communication, that's what I would focus on.
I'd like to ask you guys a follow-up question related to a lot of this discussion that gets at the issue of, okay, we're talking today about shared decision-making, and which everyone, I think, who's participating today would concur with with the notion that we need to do more of it. We need to do it better. We need to be, as you said earlier, David, more deliberative in the way we do it. And with that in mind, I'll read the following question. How do we move past the lack of time in appointments so that healthcare providers can listen accurately and authentically to families and patients?
One of my tools that I didn't set up until, I don't know, the past year was it really helps my charts messaging system, because I obviously don't always have that long of appointments. People have a lot of patients and that they have to get through, and as you said, appointment times aren't always the longest. So my concerns in between, I get to either directly message my transplant nurses or sometimes doctors themselves about my concerns that I have in between appointments, or just something that I didn't get to convey in my time slot, which has been really helpful with me, just a way for me to always communicate them and knowing that they'll see it, or knowing who will see it when I message them, because it'll say their name, have their picture, so I remember who they are. etc.
Jill or David?
Time is a major challenge, and there's no easy solution to that. What I try to tell providers is your job is to slow down and listen. It's not to get through a set series of things or questions that you have to get through. That can be done at the next visit. What I encourage families to do is bring a list. And some put it on their phone, some write it down, some have it in their head, but having a list, and that's what we start off with. Let's get your list down. Love that idea, Brendan. Some of my patients email me the list before we come to the visit. We do have to advocate as a group for for providers. We need more time with complicated patients. I mean, just how simple is that? We need more time. So there's no simple solutions, but slowing down is important.
Some of the things that I've seen out there that have been utilized, or I've seen that are pilots or being tested. One is a system called Cloud Care. That's kind of like my chart, but it is a shared system where is a team approach where families and all the specialists and it's like a virtual medical home where everybody can go in and do kind of like a virtual rounds around a complex kiddo and kind of have a virtual discussion around issues. I've seen a couple of Corey grants being proposed around developing something like that. I've seen a couple of ones around a peer-based navigation system that are in clinics where you have a peer family navigator that is embedded in clinics that works with a physician to do that extended support for families. So the physician, they work in link with the physicians within that to do the longer supports and linking them with resources and linking them with next steps and making sure and follow up and making sure that they connect to things or they can do the check-ins and things like that so that so I've seen some things like that can happen that can extend the time that is connected, but those are things that aren't typical and aren't always financially, I've seen where there've been like Rhode Island, it's a small, state, and they physicians, they pooled and they shared a navigator that would, go back and forth between, but they're a small state. So they could all share in one space. So I've seen some solutions, but they're small and far between.
To add one teeny thing to what I said, I just thought of it. I remember talking to some of my friends who also use my charts, and I know my charts specifically, or some messaging systems can differ from hospital to hospital or things like that on their formatting and their layout, etc. And I've heard people, complain from system to system on they're not always sure who they're messaging, or they're not always sure how to navigate to certain things. So I think another helpful solution would just be a look into how to make that system accessible and easy to use by everyone, because I know some people have complaints from systems to systems about those as well. So just in ensuring either research or development into those websites for navigation and usage.
So just it's 2:00, so I know some people may have to jump off, but we're going to continue this conversation because there's lots of fantastic comments and questions coming through. A reminder again, if you have comments, put them in the chat. If you have questions, put them in the Q&A, and we'll try our best to get through them. For those of you who are dropping off, please come and join us again for our next session, which will be on February 10th. And it will be on disorders of tone with Lurie Glader and Nathan Rosenberg, who will be our guest speakers, joined by family speakers, Maureen Benketer and Sarah Perkins. And the registration to that will be in your email, and registration is now open. The other quick announcement is, again, a reminder about the evaluation, which needs to be completed by January 24th in order to claim your CME. Now back to the discussion, because there's so much richness to this discussion. I want to ask another question about power and power dynamics. It's actually a comment, but I think we can turn it into a discussion. Listening and connecting still puts the power in the hands of the provider to listen. So I think to David's point earlier about listening, it's still the provider who has the control of whether they're listening or not. What can patients do to regain some of that power when someone is not listening? I think this question really resonates because I've heard it quite frequently from patients and families that they just feel like the dynamic is not in their favor. Sometimes getting out or getting a new doctor is not really a realistic solution because there may be no one else available when you are in an acute care situation or under stress and decision making. What can we do to empower patients and families? None of these are easy questions.
Yeah. With all due respect to the question, I don't, the way I conceive of things, I try not to think about power because I don't want the power in it, and I don't want the family or the child to have, I don't want power. I want people to feel like they can ask questions and they can come to me with concerns. And you're right, we have some cultural power hierarchy things that we can't change. You know, you can change culture slowly, but good luck. It's going to take a long time. The way I structure my visit by allowing patients to get their list to me with hopefully minimal interruptions by me is to put their concerns first. And maybe that diminishes that power thing a little bit. Oftentimes I've taken a little notes to myself about what I want to talk about. If we don't get to it today, we'll get to it next time. I really want to get to as many of those things as we can. And after we get that list, then I try to work together with the family. Again, I don't know how successful I am. Hopefully I am, of creating an agenda for what we can actually get done during this 20-30 minute encounter that we have.
To follow up, yeah, I think what Dr. Fox said, bring a list. I found helpful for me. Setting an agenda at the start when the doctor walks in. Also, just so yeah, start with your concerns first, as he said, or address what you want to talk about when they walk into the door. I have sent messages forward ahead of time with my charts, just so they know ahead of time and can think and dwell about it, but also so if there's something I forget to mention, sometimes they bring it up as well. And then, if none of that works, what's worked for me is, persistence. If I didn't get my concern addressed in my last appointment, I'll ask it again in the next. I know some folks don't have the pleasure of time for that, but if you do, that's worked for me, where I just keep, addressing it until I feel like I have a good conclusion.
I think I understand the question. I think I understand the concern. I think that for language, it's ensuring that there is someone there that has the capacity to interpret well. If it is racially based, I think it's ensuring that they're not alone, that they have advocacy there with them. If it is knowledge based, again, making sure they are not by themselves, that there is advocacy with them when they are there, so that there is support for choice and decision making if they feel like no one's listening, if they feel like they don't have a choice, if they feel like they don't have a voice in the decisions, and decisions are being made that are not the best for their child or their family, and they have no place else to go. There is no other choice in a physician around. That does happen. There is inequity, and it isn't an easy thing to address if you feel you have no power, if you feel you have no choice. And it isn't an easy thing to address. But I think for a family looking to see who is out there that might help them, who might help them walk back through the door and support their child, even if it's in the ER, who is the patient support that they can bring back through the door. Do they have language support? Do they have patient support to come back through the door with them for their child? So, you know, kind of where thankfully, I just was very persistent if I felt nobody was listening in some of those situations. But I also, I wasn't totally unprepared. Because I had come through having to fight some of those things with my oldest son with IEPs and getting him a diagnosis with his autism as a high functioning autistic, and with my daughter, I kind of came prepared for unknown circumstances. So I wasn't kind of new to the game, but some families are. So I understand the question.
I'd like to move to a question from Isabel, which I think Brennan and Jill, you both reflected on in your introductory remarks. And this is around transitioning shared decision-making from the parent to the child as they grow. I'm curious about the transition shared decision-making from deciding as parents and giving over that role to a child as they grow. My kids are older now and I didn't have much support in how to actually do that. Really, it was our family leading clinicians in this. I'm curious if Jill had any support in doing this.
I'm not the typical parent in doing that. And because when I got to that point, I was the statewide lead in doing that. So I was the one that had to develop the system for teaching families on how to do that. So I was at the time learning how to do it from gut transition. I was learning how to do it from the national genetics alliances. I was, but was there a lot out there in our state around it? Not so much at that particular point in time when it came to medical transition. There was through the ARCs around intellectual and developmental disability for transition for special education, but not so much around medical. And that's still, I'm finding that out there for physicians, there isn't a lot of, in care, there isn't a lot of practices that do transitional care, with their patients to adult care. They're kind of like, they're not quite sure how to do it. So parents are left kind of on their own, especially if you, if you aren't a part of the intellectual and disability, developmental disability world. So it, if you're in a state that has a family-to-family health information center, they probably have information on their website, and you can go and find it. And I can put my email in the chat, and I can help you find where that is in your state, definitely, and connect you with them. Because every F2F would have that on their website to give you that information. But yeah, I wouldn't be your typical parent for doing that, because I kind of had to be the one that developed it for our state.
The only thing I can share on that is I remember when I was younger, I didn't ask a lot of questions for myself at the doctor appointments. I was a bit more shy, and typically, you know, either my mom or my dad, whoever was with me, would ask the questions, and we'd leave, and they, you know, that was that. And as I got older, you know, I started asking more and more questions, but some of the behaviors kind of stayed from either parent, where they'd ask a bunch of questions, and I didn't always feel like I had my time to get my questions in. So I remember, it's kind of funny thinking back, but I would, you know, after the appointments in the car or something, I'd sit down with them and say, you know, I want you to let me ask my questions first, so I can get my concerns about my body out, and then you can ask your questions. So I feel like I have, you know, kind of my voice first in my care, which, you know, has been a transition, you know, and it took some work to not have sometimes my mom, you know, jumping forward with questions while I'm still in a thought or transitioning. Sometimes when available, I'd have her step out for some of my questions, just so I felt like I had some more one-on-one time with my doctor, and it could be a bit easier to convey my thoughts with just less people in the room. So the transition for me was kind of slow, and, you know, as a process of me, you know, communicating what I felt they could do better, or what I could do better, and what I need out of them to help forward me in my own care and my own, you know, decision making.
Thanks, Brennan. The next question is for Dr. Fox. Do you ever ask patients for their list in advance to help you prepare as a clinician before you enter into a clinical encounter? And the question specifically about my chart. Even though we are not encouraging a single electronic health record system, there are many in the universe, but using EHR type platforms to make that communication.
I'd preface this by saying that we have a long way to go in medicine to incorporate the variety of communication types into the medical practice, because here's what we're talking about. We're talking about incorporating email, which last time I checked was from the 90s, into medical practice in real time. So we're a little bit behind. And part of the reason we're behind is that I'm overwhelmed by the amount of communication I'm getting sometimes. So as a routine, I don't suggest that they send the list to me ahead of time. But for selected patients where I've found that we're getting cut off, we're not having enough time with the visit, that they do send it ahead of time. And then, you know, try to prioritize it for me. Some of them are some very simple questions that don't even need a discussion back and forth, you know, what's the number for orthopedics or something, you know, whatever it is. So yes, I do on occasion do that. And it has been very helpful in those select situations.
There's also a question here for Brennan, and specifically, knowing your body best is important, but is there anything that would help you build your own confidence in knowing your body? How do you build your own knowledge besides experience?
Sure. Yeah. Well, obviously, feeling everything and learning from experience is a big factor. But ways I got confidence in how to tell what I was feeling in my body and link it to, actual results that I could tell my doctors was asking my cardiologist, my physicians, everyone, what, when I'm feeling something, what can this be, and kind of troubleshooting with them. And then, if they tell me that, when I was first learning what PVCs were, I tell them, felt like my heart skipped a beat, or it pumped really fast 3 times. What exactly does that mean? And sometimes I'd notice that happening multiple times a day, right? Like conveying, 10 times today, I felt like I had some irregular beats, or it skipped a few beats, or etc. And they said, well, that's what we call, PVCs. So, going forward in the future, whenever I felt that, I could convey, oh, I had, PVCs, and I learned this term. And other things are, sometimes I experience things with machines, and the machines would write it down. With like tachycardia, with other, heart related things, or just kind of, I don't mean to bring it to experience, but I get reassurance from an outside factor, like the machines I'm hooked up to with all my stickers and everything, telling me while I'm there experiencing it. So I guess it's just asking all the questions you can about what's, and describing all the feelings that are going on in your body, and trying to get answers from people.
So Brendan, maybe I can follow up, because there's another question I think relates to what you just described. I'm going to read the whole question, but I think it's really interrelated. I'm really struck by what Brendan said. This is not about the comment you said now. This question was asked half an hour ago, about pushing his doctors to look at a specific section of his graph. It reminds me of an experience I had with my daughter's first pediatrician, who referred me to a lactation consultant and then didn't pay any attention to her conclusion that our problem was not a breastfeeding problem. Is using available data, and maybe I'll add to that, providing patients and families better access to available data, a core tool in shared decision-making, or is that something that will flow naturally simply from listening better?
For me, yeah, because like I said, through both experience and confirmation from doctors of what I'm feeling throughout the years, I became really in tune with my body and what, I feel this typically, 80% of the time it means this. So even if at times, doctors or the machines were recording saying, yes, this is what's going on, even though you told us that, you're having this is what the machine's saying, that's probably right. It helps to know that I'm kind of the master of my body, right? I've lived with it for years and years and years, to know what's going on, and having them double check even if the data is saying something else is useful.
Any thoughts from any of the other panelists on the role of data in shared decision making and access to data for patients and families?
I kind of had a similar kind of a thing for my own body, and because about 30 years ago I was diagnosed with breast cancer, and the being able to see kind of the data myself and making choice on, how radical to go with the surgery. The decision I made on the long term ended up being a good one, because once they got in there, they found more, that because I saw that the farther they got, the more they were finding, my choice was more radical. that that was a good choice in the long end. But also for Brennan in the ER, I mean in ICU, that seeing, watching, the fact that I was watching daily what was happening with his body, when they were doing they were going to do an EEG, because they were trying to determine if he was having seizures. And in the middle of it, what they thought was a seizure was him crashing. And I was trying to say, no, he's crashing. And they kept trying to put on the things and weren't listening. And so pushing to the nurse and going, you need to look at what's going on. When they finally looked and they went, oh yeah, stop. And then went, it was the data that was what drove them to make a different decision. So yeah.
I guess for my final thought, data is great and it tends to be very consistent, right, in making choices, but there can always be abnormalities or whatever, and my life has kind of been full of those, so it's always good to keep an eye out for things that would be abnormal from it as well, because yeah.
I'm gonna add, there's one more question and then I'd like to actually let everyone have some final thoughts. I just wanted to ask from the Q&A. There's a question about whether you had access to support in this whole process from a shared decision making. For Jill, did your family have access to a person who is a caregiver with similar experience, like a family advisor? And for Brennan, do you have a care coordinator involved in your care?
Yeah, I had. Oh, you can go first.
And they were all specifically around the conversation today around shared decision making.
Around shared decision making, kind of yes, in that where I work, I work in a whole office of women who all have children with special healthcare needs, and I work in a whole network of shared decision-making folks. So yeah, I had a huge network around me through this whole journey. Plus, when I started out, I was working with a network of adult disability advocates, and these guys were amazing, and they really were an amazing support for me when we started with my kids and Brennan. So yeah, I did.
And Brennan?
For me, I got around the time where I started doing my transplant evaluations, I got linked to a social worker and provider who most of the time would, I'd go meet with, and he'd say, okay, no, no doctors, no parents, no nothing. I'm gonna sit down with you and we're gonna talk, kind of go over all these decisions that you're making and just kind of help you work it all out in your head so you can make these thoughtful choices and decisions with help, right? So that was one resource that was linked to me, and he helped me throughout all this process, and talked to me about all my appointments and what all these things would mean, which was really helpful for me.
So almost like a third party
Yeah.
to the shared decision-making process. So maybe we'll just end with just some concluding thoughts. So reflecting on the conversation today, which was, again, thank you for all the fantastic comments in the chat box and the fantastic questions today for everyone who's participated. I was just wondering if Jill, Brennan, David, you have any concluding thoughts on what we've been discussing for the last 90 minutes. Maybe we'll begin with Brennan.
Sure. Yeah, as we kind of repeated the word a lot throughout the panel, but listening, both patient and doctor, is very, very important. And not just hearing, but kind of thinking and dwelling on it. So not always in the literal sense. For listening and communicating is the biggest takeaway from the most part, and being a little bit flexible in your treatments. As Dr. Fox said, that was great. With the two examples, the left had the correct treatment for the left, but the right had the correct treatment for the right. So just individualized care how you can do it, and knowing that not everyone would want the same, golden standard of treatment is important to take away.
Jill?
Thank you for letting us be a part of this. Thank you for honoring our story. And I appreciate being a part of this. And yes, listening is critical to good care. So I appreciate being a part of this.
David?
I'm going to echo what Jill just said, and that's the appreciation. It takes a lot of work and effort and time to put these discussions together. So I appreciate everybody who was involved and helped get it done. Also appreciate the people who sent comments in. I was able to look at a few of them, and in particular, Isabel's comments are really thought-provoking for me, and so I appreciate that going forward. And I guess lastly, I try to remind myself every day when I'm about to go down to see patients right now, it's a privilege. It is a privilege. It is my privilege to participate in the lives of people and their healthcare in such a deep way. That helps remind me and center me to try to be humble, try to show some humility when you come across things you don't understand or don't know what to do with. This has helped to remind me how important that is. So I appreciate that.
And on that note, I just want to thank everyone again for joining the seminar today. I hope you enjoyed it as much as I did. I have learned a ton, and special thanks to Brennan and Jill for sharing your story with us, and David also for sharing your insights. We look forward to having you join us in future seminars as well, and hope everybody has a wonderful day.